Happy Tuesday and good afternoon. So welcome to Beds and Baker Research Exchange Series. My name is Miriam Borath, the UC founding co-director of Innovate for Health, I4H. I do see a lot of people return as a returning participants from the previous sessions. So I will do this intro very quickly. As you know, we created this series as an opportunity for the Innovate for Health team to connect with the wider community at UC Berkeley, UCSF, and J&J, and to foster new collaboration. Our immediate goals of this forum was to share the Innovate for Health research projects with a wider audience and to increase engagement, and we have done just that. Quick update about our past events. Since November of last year, you have heard from our first cohort of fellows every month. Now all the videos are online and you can view them through our website, innovateforhealth.berkeley.edu. You can also browse our event page to register for the upcoming sessions. Please do that. We appreciate your participation. I think most of the people here are familiar with the structure of our fellowship by now, which is a 2-year-long fellowship and is structured in 3 different phases. We recruited our second cohort in November of last year, and many of you have briefly met them during our kickoff event back in November. They are almost 6 months into their fellowship now and about to complete the project ideation and innovation phase. So we decided for the next 3 months, including this one, feature 2 of our new fellows at each session, where they get an opportunity to introduce the research project and the unmet needs each have identified in the past 5 months and a half to our community and get feedback. So our theme for today's session is Holistic Clinical Care Platform. We have 2 of our fellows here, Dr. Ben Lakar and Dr. Akram Bayat. Ben is working towards helping clinicians screen for social determinants of health and provide intervention by creating a mechanism to extract social determinant data from patient medical records to better facilitate informed and targeted care, and he's going to talk to you about that. Akram is working towards helping clinicians to think more holistically and thoughtfully about patient care for complex patients by developing a software tool or a dashboard to support situational awareness in physician offices by extracting relevant information from patient medical records. So before I pass the virtual microphone to Ben and Akram to introduce themselves and start their 20 minutes presentation, I would like to plant a seed for our 2 upcoming events. Remember, these events are first Tuesday of each month, so don't forget it. On May 4th, our theme is Digital Health Platform, and you will hear from Dr. Mitra Vankipuram and Dr. Saeed Sayedi. On June 1st, our theme is Medical Imaging and Oncology, and you will hear from Dr. Elizabeth Smith and Dr. Reza Iqbali. So with that, I will hand it off to Ben. As a reminder, these sessions are recorded. So, and please hold off your question till the end of each talk. We have programmed about 10 minutes Q&A. But during the presentation, feel free to enter your questions or comments in the chat, and Andrew will help Ben and Akram to moderate that space by either reading off the questions or asking you to unmute yourself and ask the questions yourself. So I'm going to stop sharing, and Ben, you are on.
Great, thank you, Miriam. I will share my screen now. Can everyone see that?
Yes.
All right, great. So thank you very much, everyone. Thank you all for attending. And before I get into my project, I'd like to briefly introduce my background and myself. My education and work experience centered around neuroscience, single-cell sequencing, and bioinformatics. At my different stops, though, I was participating in different volunteering and mentoring activities. And so in my last couple of fellowships, including this one, I've been really focused on a project that improves the underserved populations, and in this case, improving healthcare for the underserved. And so I'm very interested in applying data science and AI in this project for underserved populations. And that's how I arrived at this project called Socioeconomic Risk Screening, Documentation, and Interventions. It's working primarily with Dr. Laura Gottlieb and Dr. Matt Pantel of UCSF's Social Interventions Research and Evaluation Network. Today, I'll talk about social determinants of health, and then I'll talk about the screening portion of of the project, including applying NLP to collect social risk and assets, and then also leveraging public databases. And then ultimately, we want to apply interventions and recommend interventions in response to the screening results. So what are social determinants of health? The CDC defines them as the conditions of the environments of people that affect a wide range of health, functioning, and quality of life outcomes and risks. Specifically, there are 5 that they recognize, as you can see here. One thing to recognize is that social determinants operates on multiple levels. You have the upstream on the left, and then the downstream and how it affects health outcomes on the right. You know, on the left, we have things like social inequities and classism and racism that feeds into institutional inequities at the level of programs and policies and government agencies. And at the living condition, you start to get closer to how it can affect people on an individual level, such as the healthcare access people have and the level of education, et cetera. And then that feeds into alterations in behaviors and then feeds into ultimate downstream social determinant of the health outcomes. So a little bit more concretely, here's some facts about how social determinants may influence health. For education, you know, babies and mothers who did not graduate high school have higher infant mortality. In the neighborhood level, if you live in a food desert and we lack access to grocery stores with healthy foods, that can lead to poor nutrition and higher risk of heart disease and obesity. And then for occupation, some may have different work-related stresses that may lead to unhealthy behaviors such as smoking. So I'll be using different terms throughout the presentation. I just want to make it clear about you know, how we're choosing to use these terms. For social determinant itself, that affects everyone. It affects you, it affects me. Some people can be positively affected and some people can be negatively affected, which is a social risk factor, which is the second row. And those are associated with adverse social conditions. And people may use these in different ways, but in the way I'll use it, a social risk is something that can be uncovered in a clinic provided screen. These can be things like social isolation, food insecurity, homelessness. A social need is something that a patient identifies as an opportunity for intervention. And it's not always the same as what a clinic identifies. So for example, someone may screen negative for food insecurity, but they still may benefit from having SNAP payouts or food stamps that allow their money to be spent elsewhere. Now, behavioral risk factors are not the same as social risk factors, but they can be often intertwined and feed on each other. And modifying behaviors depends heavily on one's context. So it's harder for people to eat healthy if they live in a food desert. So the unmet need that I seek to address is to find strategies and create strategies for extracting social risk and asset data from EHRs to personal care delivery based on a patient's social conditions. Now, I really see the ideas of screening and intervening kind of intertwined, and that's why I have this this cycle here, because you know, for some people they don't want to disclose their social risks if they don't have an intervention or if there isn't some sort of way to address their social risk. But I'm breaking these down into my aims. So aim 1 is to facilitate collection of patient data on social risks in structured fields. Aim 2 is extracting social risks in historical records. And then they're in 2 sub-aims. One is mining clinical text or unstructured data. And then second is linking the address to public databases. And then aim 3 is on the intervention part or on the personalized care delivery part of the project. So in terms of project outcomes, you know, I really want something to be useful to the clinicians, something that can be actionable. And so the deliverable there's 2 deliverables, an algorithm and dashboard and a policy. So the dashboard and algorithm would help clinicians facilitate social risk documentation, and then related to the third aim, provide personalized care delivery based on their social conditions. And then broadly speaking, the idea of promoting social risk and asset data collection is something that I hope to promote and encourage different hospital systems to make this a more regular practice. So with regards to the first aim, health professional organizations have increasingly recognized that social diversity impacts health. So this figure is from Matt Pantel, one of my lead mentors, showing how the publications in terms of social informatics has increased quite dramatically over the last 2 decades. And on the left, you can see different professional organizations that have endorsed social screening in that time frame. So when I first started this project, I was not sure what the term screening meant. And so those different organizations that I showed in the last slide, they have different kinds of screening tools and questionnaires. So I'm showing one example here. So this example is from the Centers for Medicare and Medicaid Services. It might be a little hard to read the text, but I'm not asking you to read through it. But it just sort of gives you a flavor for what can be asked. So there's things like related to living situation, relating to food and food insecurity, what kind of transportation options you might have, et cetera, what kind of, how's your ability to pay utilities. And on the right, I'm showing how UCSF has started to, put EHR systems or populate EHR systems with social determinants modules, or you might call it social determinant wheel, which allows for shared documentation. But as you can see in this example, social determinants are not broadly documented yet, and that's for several reasons. Probably the most immediate is that there's just a logistical consideration, is that there's limited time with the patient. I mean, social risk screening is deprioritized. There's lack of incentives to complete structured fields. So the project outcome in this case is to facilitate documentation of social risk in a patient medical record. A simple thing is, patients are already entering things in free text fields, but you can facilitate a structured documentation by allowing the clinician to auto-select an ICD code associated with what they type in. So for example, homelessness is associated with a Z code of Z59, and that could facilitate the workflow. So there's been a national movement that was actually initiated by Siren called the Gravity Project that is trying to create electronic standards for social determinants. And so I'll be closely tracking that project's progress. So for aim 2A, that is extracting social risk from clinical texts. And so EHRs, again, are not going to contain a lot of social determinants or social risk in structured fields, but they will more likely be in free text notes. And so in this case, I will apply NLP to collect behavioral and social data from text. And again, I'm the first person to think of this. There's a publication history in terms of different, both social and behavioral risk factors identified and with different approaches. And even at UCSF, I got connected with Dr. Amelia DeMarcus, Dr. Thomas Peterson, Sam Pack, and Dima, who's at Baker, and using NLP to extract social determinants for physical therapy patients. And they have plans to use CTAKES and Moonstone to look at living situation, transportation, food, and access to utilities. And I've been fortunate to partner in their efforts. So I have access to both an orthopedic set, which is the set I just mentioned, and also the machine redacted set that was Baker curated. And some of you are familiar with the Baker curated set on the right, but they're mostly de-identified, they're waiting certification. And then in terms of the notes that I'm going to focus on, I'm going to focus on the pediatric set, just because of the specialty of my lead mentors. On the left column is the orthopedic set. It's for chronic low back pain patients. And the big advantage here is that they are labeled, or they're in the process of being labeled, and they also have multiple annotators to try to see the variability in terms of labeling. So what I did with the machine redacted set is I took some of the manual labeled text that the labelers had identified, and just tried to get an idea of what could be in the machine redacted set. And so There are different categories of behavioral and social texts on the far left column. And then in the second column, you see different terms associated with those behavioral and social. I can't even say risk or asset at this point. You know, is there social information there? And then on the third and fourth columns, you can see the breakdown, and you could get an idea. You could see that social relationships are in a fairly high proportion of the machine redacted notes, and housing situation is there as well. All right, so I'm also aware of some of the challenges of clinical text as I start to look into the data. There's vagueness in documentation, there's shorthand, grammatical errors, of course, and also there can be some ambiguity about whether a social determinant is part of the current or past history. So in terms of our project outcome for this sub-aim, the input would be taken in clinical notes. The output would be identifying the social risk or social assets, and then associating the appropriate ICD code. And then my role would be to augment or to create an NLP algorithm to make that process happen. So for AIM2B, this is linking a patient's address to databases. And what I mean by that is, in the absence of patient level data, community level or neighborhood level information can be used as a proxy for that patient. Because zip code and address is well populated in patient records. And this can help identify whether a patient lives in a food desert, has access to public transportation, or resides in an area of a recent crime event. There's different databases that I'm starting to look at. So one is the Area Deprivation Index, and different online resources can be used to help identify food deserts. And then the census is pretty detailed. I've taken a look at this data in a different project, but you can have an idea of what proportion of the population has what kind of income benefits they have, what's the breakdown in terms of private and public insurance, the worker class, what % of people use public transportation, et cetera. So in this sub-aim, this would be alerting clinician to community level circumstances when encountering patients for those neighborhoods. Again, identifying risk for things of whether they're in a food desert or recent crime, something along those lines. Okay, so this brings us to AIM3, which is the intervention piece. And so this would be for both clinicians and social workers. In the case that a social worker is associated with a clinic. And here I'll define a few more terms from that same review I mentioned earlier. But there's the term social needs informed care and social needs targeted care. Informed care you can think of as an adaptation that a clinical setting might make to account for a patient's social circumstances. Common examples are providing transportation to hospital appointments, or providing translators, which is often done in a lot of settings. And social needs targeted care, the second category, helps address the needs more directly. So it provides access to income assistance or links them with transportation, food, or housing supports. All right, so in this case, this will work hand in hand with a screen. So if a patient is homeless, for example, then that means they're at risk for housing instability. You'd want to, for one example, determine if a patient has appropriate immunizations, such as hepatitis A in the case of homelessness. And an example of targeted care to help address that need more directly is refer them to shelters. And a couple more examples in the case of hunger, then that's they're at risk for food insecurity. And so you limit medications that should be taken with meals, and for informed care. And then in terms of targeted care, food banks and federal assistance programs are options for in that case. Okay, and so this is my project plan. I'm looking at both screening, documentation, and interventions for patients at risk for different adverse social conditions. My next steps, these are kind of broad, but I'm going to continue learning about the process for adding features to an EHR. I will iterate towards the application of novel deep learning algorithms for the extraction of social and behavioral data from clinical texts. And I want to better understand the process of integrating public database information from EHR. Points 1 and 3 are less data sciencey and more trying to understand how to navigate some of the EHR systems, whereas the second point is probably the more data sciencey aspect of the project. All right, so in summary, I'm going to just like to emphasize that social factors can exert a large influence on health outcomes. So I think this is relevant for no matter what your disease of interest is. And then I've already emphasized I'm going to create tools to help clinicians. But on a closing note, I just want to emphasize the ethical considerations should be paramount. Interventions done without attention to equity will invariably worsen inequity. So on that note, I'd like to thank a lot of people. I'd like to thank my primary mentors, Laura Gottlieb and Matt Pantel, and then also other people who've been involved in the project or helped me in the project, Emilio DeMarcus, Thomas Peterson, and Sam Pack, and Sid Jane. I'd like to thank the co-directors for the stewardship of the program, Emma and Miriam, Andrew for helping manage the program, Dima, and other members of the Baker staff who have helped get information commons on board and have been involved in the clinical text effort for all of us, my fellow fellows, and my joint steering committee. So thank you very much, and I'm happy to take any questions. If there are no questions at this time, let's see.
There's a question on chat, Ben, from Elizabeth.
Okay, yeah, I see it. Is there a way to expose information about social determinants beyond in the patient's EHR Z code? Elizabeth, do you want to elaborate on that question? I'm not sure what you mean.
I'm just kind of curious, like, I guess the thought that I had was, imagine you developed algorithms that were really good at, extracting this information. Could that be used by the healthcare system, like UCSF itself, to try to get more resources or to somehow coordinate like larger efforts or something like that? Have you thought about that?
Yeah, I think it can vary by department, to be honest. Just different departments are better equipped for addressing a patient's social circumstances. So I think if it is in the UCSF system, the information can be available to other people at UCSF. But in terms of the capability of actually doing something about it, that's going to vary by department. All right, Sharad also asked, perhaps you could discuss the regexes. So that's regular expressions used by the redaction to help you find the right engrams and notes, allowing also for spelling errors. Oh, I see. So that's a recommendation on that. So thank you, Sharad, for that in terms of my second name.
And then Mithra,
yeah,
follow up.
Yeah, in terms of common errors, to be honest, the most problematic, and I think this would kind of put a ceiling on probably the performance of whatever NLP model can generate, is I think the biggest hurdle, I think, is just the quality of the documentation itself. So what we're seeing in the manual annotation is variability. So there's 5 labelers, and there can be quite some variability in terms of what people recognize as social risk, and so I think if humans who are looking at this closely are having problems characterizing that, then I think it's hard to expect that a algorithm could rescue that. So yeah, that's probably the main thing that need to keep in mind.
Thank you, Ben. A follow-up to that question about inter-rater reliability with labelers. I got very curious about whether it was possible through the data science to come up with an estimate
of inter-rater reliability retrospectively from the data?
I don't know about retrospective, but DEMA is calculating a Kappa-Cohen score, I believe. That's what it is. So it is a rating to show.
Is the standard for inter-rater reliability, yes.
Yeah. So that's something that they're already doing. I don't know if that addresses the retrospective aspect, but yeah.
Oh yeah, so that answers my question, that yes, it is possible to look at the data retrospectively and infer what the Kappa-Cohen score might be for inter-rater reliability. Thanks.
Thank you. All right, I'm just about at time, so at this point, I will hand it over to my colleague Akram.
Thank you. Thanks, Ben. Maybe a round of virtual applause from everybody. Clap, 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 clap.
Okay, thank you so much, Ben, and thank you, Mariam. I share my screen. I hope you can see my screen.
Nothing yet.
Not yet. Okay.
Oh, we can see your screen. Perfect.
Okay, great. So hello, everyone. My name is Akram Bayat, and I'm very happy to be here and present a high-level description of my project, which is about building a dashboard to support situational awareness for primary care clinicians. A little background about me is actually I'm a data scientist and I have PhD in computer science. My PhD research focus was on applying machine learning and deep learning techniques to various real-world applications, such as biometrics, identifying people, and interface design based on the human eye movement behavior, also human activity recognition using wearable sensors, plus improving performance of deep visual systems, including object recognition and scene perception systems based on the mechanisms in the human visual system. After my PhD, I started my postdoc at the MIT Media Lab, where I was working on the intersection of machine learning and healthcare applications. We developed a deep generative models for computational staining of pathology slides. I also developed an automated end-to-end system for detecting and grading of tumors in pathology whole slide images in prostate cancer. My other work was actually analysis of electronic medical records for early diagnosis of diseases. And then after joining to Innovate for Health program, my work at Innovate for Health fellowship program started with exploring unmet needs in healthcare space and then finding a solution that can be deployed in clinical setting. My project topic actually was initiated after talking to so many great researchers and clinicians at UCSF Berkeley and J&J. As of objective of today's talk, first I would like to introduce two concepts. First, the concepts of situational awareness and how clinicians apply situational awareness in healthcare, and then what patients are considered as complex patients, and further the important link between situational awareness and clinical outcome for complex patients. Situational awareness refers to being aware of what is happening around you, where you are in relation to other people or systems. And the concept of situational awareness have been around for many years in many areas, such as healthcare, military, etc. And maintaining situational awareness when dealing with the complex systems will help to prevent the error and improve the performance of the system. Situational awareness, as you can see in this picture, has three levels. The first level is perception, which means the person must have access to the relevant information. Once the access is in place, the person has to recognize it. In the higher level of the situational awareness, which is comprehension, based on the information gathered actually in the perception level, the person tries to put together all those information and try to make a decision. And in very higher level of the situational awareness, which is projection, the person can actually project what would happen based on the decision he has made. And as you can see, it would have the direct impact on the decision making, and we will have a feedback to and we will have impact on the complex system. In the concepts of healthcare, when we say clinician maintaining situational awareness, means they understand what's happening with the patients using the information, and they do the diagnosis and what would likely to happen in the future for that patient. In this picture, you can see the actually process of maintaining real-time situational awareness in healthcare, and the critical link between the situational awareness and clinical decision making. As you can see in this picture, when the patients visit a doctor, and the doctor will pull the information from different resources, such as patient's electronic medical records, such as vital signs, medlist, lab results, symptoms, or prior history, and then try to understand those information, put together, aggregate those information to decide obviously what to do and what diagnosis is for this patient, and also the impact of condition on health, the impact of other factors on this health. And in the higher level, which is the actually projection level, the clinician will actually decide, will say what prognosis would be in the result of this diagnosis. There is, as you can see, there is a very important link between the situational awareness and decision making, and also this decision making will have direct impact on the patient's outcome. So that's why the situational awareness and maintaining the higher level of situational awareness for clinicians are very, very important. The second concept that I need to elaborate on it is a complex patient care. Situational awareness particularly plays an important role when clinicians see complex patients. A few research have been working on on a conceptual definition of the complex patients, but in our actually work, we define complex patients as individuals with multiple chronic conditions, because people with multiple chronic conditions shows very dynamic health conditions. Situational awareness here has a key impact on the decision making for optimal treatment of multiple chronic conditions, in order to make sure we actually deliver optimal management of care to the patients that have chronic conditions, which also have the complex health need and dynamic health needs. Chronic conditions are important because approximately 1 in 4 Americans has multiple chronic conditions, including 1 in 15 children. Also, among Americans aged 65 years and older, approximately we have 3 out of 4 persons with multiple chronic conditions. In addition, 2 out of 3 Medicare beneficiaries have MCC, or multiple chronic condition. And at the end, multiple chronic conditions are associated with substantial healthcare costs in the United States. As you can see in this figure also, people with multiple chronic condition are at increased risk for mortality, poorer day-to-day functioning, hospitalization that can be avoided, and also the disability. And these patients may receive conflict advice from the physicians and other healthcare providers. Also, the US Department of Health and Human Services administer a large number of federal programs directed toward management of multiple chronic conditions and improving health outcome in individuals with MCC. And improved management of these chronic diseases can help reduce the hospitalization, disability, missed time from work, disability, family responsibility, and overall healthcare costs. And you can see that clinical situational awareness impact the delivery of health system and would impact in all of these, actually, all of these factors. There are some obstacles that impede situational awareness. One of the important of them is the time constraint. PCC or primary care clinicians see an average 20.2 patients per day. It means 20 minutes visit per visit. Also, new patients are another obstacles, because new patient visits require more work than established patients visit at the same level, including detailed history, detailed exam, decision making with high complexity. The next one is EHR usability, which is the main obstacles for maintaining the situational awareness. The reason is that the EHR design is not compatible with the clinician's practice that cause issue relating to the cognitive workload in cognitive work in EHR. And at the end, we have a clinician burnout that in a study in 2015, it has been shown that 46% of physicians is experiencing burnout at a given time, that burnout is directly linked to the higher medical error rates and also malpractice risk. So based on that, after I talked to so many clinicians to figure out the real unmet need regarding the problem of maintaining situational awareness in clinicians, we figure out that you can see here an example of the two examples of the clinician's quote that I bring for you. For example, one of them says, an automated situational awareness tool would be extremely helpful to our very busy primary care providers to expedite chart review and reduce the cognitive burden of using the EHR. Based on what I said so far, our goal during this fellowship at Innovate for Health program is to create supportive tool or dashboard for clinicians to to contribute or support the situational awareness for clinicians, specifically when they treating patients with multiple chronic conditions with complex health needs. The actionable output for from a PCP's perspective in my project would be to design a tool to allow the PCP to launch a visualization within the EHR record that will give an overview of the patient's current status and will actually help the PCP to easily understand the patient's overall clinical status in very shorter time than before. As you can see in this picture, in the left side, you can see the EHR that clinicians have lots of problem dealing with the EHR, and the right side, our dashboard, our proposed dashboard that can help the clinicians to actually support their situational awareness when they see the complex patients. Our actionable output for our project would be an integrated display for better management of multiple chronic condition in primary care, and we will use the Smart on Fire application. An important fact in multiple chronic condition patients is that caring for individual disease or individual condition would not work. It's important to consider the care of the whole person. The reason is that the majority of patients with chronic illness have comorbidity. It means, for example, a patient with type 2 diabetes who is depressed and obese and has coronary heart disease and osteoarthritis. And the second reason is comorbidity interact or to produce the complex and challenging clinical dynamics. It means medication, for example, for one condition have adverse effect that may worsen the other condition. Also, MCC patients usually seek care for all of their comorbidities. They don't like to go, for example, for diabetes clinic in one day, for for nutrition in the next day, for example, heart specialists in the next day. They would like the primary care take care of all of their condition at the same time. So based on what I said in the previous slide, our vision is to provide a holistic view of patients' medical journey instead of caring for individual condition. This is how our work will be different from many individual dashboards that exist for different conditions like CHF, diabetes, CKD, or other chronic conditions. In terms of actually scalability, our vision is to actually cover all multiple chronic conditions, because when patients see a doctor, we don't know which chronic conditions they have. But considering the timeline of this fellowship, which is 15 months only for the implementation, in order to meet the minimum viable product requirement, we aim to start with multiple chronics based on some criteria that we actually came up. The first one is the chronic conditions that have substantial human cost. Second is the chronic condition that can cause secondary chronic conditions. The next one are difficult to manage. The fourth one is have established clinical guidelines. Sorry, it's prioritized by clinicians, and at the end, we have data available at UCSF health system. Based on that, we came up with the list that you can see here: diabetes, CHF, congestive heart failure, chronic kidney disease, and dementia, hypertension, and COPD. But actually, our aim for later after this fellowship would be to extend it to actually benefit all other patients with all type of multiple chronic condition. My project plan, as you can see in this picture, has three main parts defined through three specific aims. The first specific aim is to identify the contents and useful clinical indices for our dashboard, in which those content create a holistic view of patients and contribute to supporting situational awareness. So as you can see in specific aim 1, we have two parallel pathways in order to find or identify the information we need. The first one is based on the human-centered design, and the second one is based on is actually data-driven strategies. In in the first part, which is human-centered design, we are trying to actually interview with many clinicians to find the strategies that they use for treating patients with multiple chronic conditions. In data-driven design, we use analyzing the UCSF health system data in order to generate actually universal strategies and standards for describing the health trajectory of patients with multiple chronic conditions. We may be able to extract some useful information that help clinicians to build, the holistic view of the patient. In the second specific aim, actually, we aim to design a dashboard that represent the information that is derived in a specific aim 1 in actually a straightforward graphical or textual format. The design dashboard aims to support user situational awareness by reducing the cognitive workload. So here we will have lots of, this dashboard will be interactive and will involve human in the loop instead of fully automated process. So here we actually will need lots of UI UX design in order to see where to put which information where, and also which visualization strategy we should actually use to decrease the cognitive workload. In the third specific aim or third part of this project, we will use evaluation. We will evaluate the effectiveness of the design dashboard to justify the support of situational awareness and its adaptation in clinical setting. So, for example, it should be appropriate for users' workflow or clinicians' workflow. As you can see, we have different other parts. For example, the regulatory approvals. there are lots of works in order to be integrated into the EHR. We need to have access to the EHR APIs. So we need to actually consider that. The other, there are lots of interviews in the part of content extraction and also in the part of evaluation will be conducted. In terms of measuring the impact, there are lots of actually, we consider some metrics. One of them is the pre-implementation impact measure. So it means we can use the clinician's code and literature review to show the impact of our work. The second is evaluation during the project development. For example, the number of the clicks or keystrokes and time it takes to evaluate information for the complicated patients with and without the visualization or our dashboard. The third one is clinicians' rating of usability of our dashboard. We also can measure the value of information. And at the end, it's not actually doable during this fellowship program because it's a long-term impact. So we can measure the improving patients' outcome and reducing clinicians' burnout by supporting situational awareness. However, there are lots of confounders in this actually metrics. For example, we can measure number of the MCC visits, hospitalization, patient satisfaction, and etc. Here you can see the roadmap of actually, or I can say the expertise and the skills and different areas that the different actually algorithms, methods that will be used in my projects. So for example, user research, quantitative data analysis for analyzing the interviews with clinicians. I will use the NLP for analyzing the clinical note. I will use UX UI for visualization. We will use the Smart on Fire app and big data analysis, machine learning and deep learning, for example, for the finding the risk of moving from, for example, one chronic condition to the other one. So we are open to collaborate in all of these actually areas that I mentioned here. And in the right side, you can see my email address and also Innovate for Health program email address. Please reach out to us if you would like, if you have any idea, if you think you would like to collaborate with us, if you have any, comments, I would be appreciated. You can see the web page for the Innovate for Health program and also the link for today's talk if you want to see it later. At the end, I would like to appreciate the co-directors for their continued support, Mariam and Emma. I would like to thank Andrew for coordinating everything. And I appreciate especially my mentors, Dr. Ida Sim, Dr. Chasins, and Dr. Thomas Arendt from J&J. I also I would like to thank the fellows 2019 and 2020 fellows for all the help. Thank you so much, and I will take any question you may have.
We did have a question during the talk from Madhumita Sushil, and she asked, was a list of chronic conditions found by manually reviewing the criteria and comparing with the UCSF patient cohorts, or was it more automatic?
It wouldn't be automatic. For sure, we will use it, the UCSF data. Oh, okay. So actually, we will, as I said, it has two steps. One step is to talking to the clinicians, make sure that the methods or the conditions or strategies we come up is consistent with the clinicians' practice or workflow. And in the second step, we will use the UCSF data. Again, after extracting the strategies, we will use the clinicians to evaluate and validate the strategies we came up. I hope I answered the question.
Yeah, thank you.
Yes. The second question, will the holistic view dashboard be integrated into EHR? This is our actually vision to integrate it into the EHR, but as I said, there are lots of regulatory approval to be able to integrate it into EHR. But actually all of our foundations or techniques we use is in order to actually plug it into the EHR, that clinicians can use it easily just by actually pushing one button, can access to our dashboard. The next question is, any thought around how the team might be able to make visualization more interactive with perhaps interactive explainability? Can you elaborate on this, Mitra?
Sure. I'm just curious, if the visualizations will be read only, would there be opportunities to interact with the visualizations to further get to the relevant EHR data? Perhaps there are opportunities for explainability through interaction.
Okay, yeah, got it. So yeah, for sure, the dashboard will be interactive. It means our dashboard will have different granularity level at the beginning, because in the first level, maybe the physicians need to see what type of information, and then later on they want to zoom in or zoom out based on the patient's condition. That's why I said we our actual visualization dashboard is not 100% automatic. So it means we will keep the human in the loop in order to actually have this interactive dashboard to actually use the 100% of the potential of our dashboard. I think the Shurat has a question. So a leading PCP doctor studying this area is Ida Sim. If you can find time to discuss your assumption with her, her most important question is what really stands out for this patient? What should I know about them above just what they are supposedly coming in for? Perhaps this is intended to be covered by your second so what question. Yeah, sure. Dr. Ida Sim is my mentor, primary mentor for this project, and we are discussing this project. Thank you. Mariam, you're mute.
Thank you. If I can ever figure out this meeting situation. I think we're coming down close to an hour. If there is no more question, as Akram mentioned, please feel free to reach out to us, to the fellows. They would like to hear from each and every one of you. The feedback and the comment you provide, it will really help to shape the project. So please stay in touch and stay engaged with us. And with that, I wanted to thank Akram and join me in giving another round of virtual applause and appreciation for Akram and Ben for the great presentation they give us. Thank you so much. And we'll see you guys in a month.
Thank you.